Thank you very much, Sabrina. And this morning, and I think for much throughout this workshop, there's been a lot of talk on Dolutegravir, so I'll still talk more about it, this time focusing on children and even neonates. So as a background to that, Dolutegravir, and especially the ART that is based on Dolutegravir, are now the preferred among children and adolescents. And this is because it has been proven to have a high genetic resistance barrier. It is versatile for use in first line, second line, and third line regimens. It's relatively good with regard to side effects, and it's also tolerable in a way that people are found to be better when compared to other regimens. And it's taken once daily, and for pediatrics especially, there's a dispersible tablet that is dissolved in water, and when you do that, you don't remain with a bitter taste. So because of that, many guidelines are adopting use of Dolutegravir. However, for the neonates, the 2021 WHO guidelines recommend use of Dolutegravir, and for the moment, Dolutegravir is not yet licensed for use in that age group. But there are some studies, as we shall see, especially pharmacokinetic studies, which give us hope that it could also go as low as that. So the treatment outcomes that have come out among children and adolescents show that the results are encouraging. And in this session, I'll go over some of these results, and we'll see, especially the new ones coming out among neonates, probably exciting. Now, as a reminder, these are the 2021 first-line ART recommendations of WHO. Dolutegravir is pretty much the drug that is preferred across all age groups except neonates, where it's Dolutegravir based. The others are the other options that we are used to, but just like in adults, all the way up to neonates, we have Dolutegravir-based regimens as the preferred regimens. So these are the studies that I'm going to highlight that provide some evidence towards use of Dolutegravir among children and adolescents. Odyssey is one we heard about it this morning in the VIV symposium. There's the IMPAACT P1093, which also used Dolutegravir. And then there's DOLPHIN 1, which was among pregnant women, and they followed up the neonates shortly after birth. And there are also some pharmacokinetic studies among neonates that I would like to report briefly about. So Odyssey, as a reminder, because those of us who are here in the morning, you heard about Odyssey in a greater detail. This study is published. The publication is freely available. One could read it. But really, this was a randomized trial that was comparing Dolutegravir-based regimen versus standard of care in children that were either starting first line or switching to second line ART. So this is the design of Odyssey. There were children that were less than 18 years of age who were either starting or switching to second line. These were 700 in total, but there were two groups. Odyssey A, which was concerned with first line ART, and Odyssey B, which was on second line ART. So these were randomized in equal proportions to either receive DTG or the standard of care. And the standard of care for the first line was NRTI and NNRTI based, whereas for the standard of care for the second line was very largely PI based. So these were followed up to 96 weeks, and the primary endpoint was a comparison of either biologic or clinical failure. The combination, the endpoint was a composite one of having both of them. So this, the primary outcome, as I mentioned earlier, was virologic or clinical failure by 96 weeks. Virologic failure was defined as having an insufficient viral load response of less than 1 log drop at week 24, and then if the ART was switched to second line, or you having confirmed viral loads over 400 copies per mil at any time after week 36. Clinical failure, on the other hand, was defined as developing new or recurrent WHO stage 3 or 4 events or death due to any cause. So this was the study population distributed all over the world, but majority really from Africa. In fact, about half of them were from Uganda, the others were from Zimbabwe, South Africa, Thailand, several centers in Europe. All these contributed to the total population. The ART, the first line ART was quite well distributed among them with various regimens that they had before, and the prior exposure for those that were in second line was about 5.5 years, and most of them were on NRTIs and NRTI-based regimens. And pretty much the median age of the children was about 12 years. The ratio of male to female was about 1:1, and they are fairly stable. Only 26% of them had WHO stage 3 or 4 events at the beginning. Only 22% had CD4s less than 200, and the majority were really from Africa. So along the way, an additional cohort was established for those that were less than 14 kilograms, just to evaluate some of the newer formulations that were developed to assess the PK for those that were 3 to less than 6 kilograms, 6 to less than 10 kilograms, and those 10 to 14 kilograms. These 85 were enrolled and followed up in the same way as the ones that, the older ones, and also there was a comparison between DTG and standard of care. They were followed up for a median of about 120 weeks and then assessed afterwards. So as we had earlier in the morning, the proportion with the primary endpoint, the proportion with virologic or clinical failure by 96 weeks was far superior in the DTG arm when compared to the standard of care arm. The same observation was made in the less than 14 kilogram cohort. So that's why, whereas the study was designed to assess non-inferiority, but in fact, we found that DTG was superior, and that was very, very encouraging. When assessed for the clinical events, no major difference between the two arms, and then also for the adverse events that occurred, the ART modifying events, in fact, were more in the standard of care arm than in the DTG arm. So that also was encouraging towards use of dolutegravir-based regimens. And the same observations were made in the children that were under 14 kilograms. And there was no difference between the two arms in the ART modifying events or the advanced events generally. So really that also coming out in an encouraging way towards use of DTG-based regimens. So what about immunologically? Was there any difference? The difference in the increase in CD4 count from baseline was not statistically different between the two arms, but in both arms the CD4s increased significantly. And then what about, there are concerns about DTG and lipid profiles. There was no significant difference between the two arms regarding cholesterol, and also for the children that were under 14 kilograms, here there was some bit of a difference, but we think this one, when you look at it a little closely, the standard of care arm had slightly higher than that, but probably it could be looked at further. But what is encouraging is that at least the DTG arm was not unsafe to use. Anthropometrically, the children, the weight, the change from baseline the children all increased. There was no difference between the two arms. The BMI for age changes were similar between the two arms with no statistical difference. So what do the Odyssey results teach us? One, that the DTG-based ART was superior to standard of care, whether on considering virologic or clinical failure by 96 weeks in total, and also with the children starting first line or second line and across all weight bands. There were no safety concerns regarding DTG, and these results are encouraging and support the WHO recommendation to roll out DTG-based regimens among children either starting first line or switching to second line, and it allows harmonization with adult programs that are very much DTG-based. So I'll go on to another study, the IMPAACT P1093. This one was earlier than Odyssey and probably having longer follow-up. It started off as largely a safety and immune response to DTGs among HIV-infected infants, children, and adolescents. And this started off with 23 treatment-experienced adolescents living with HIV. These were 12 to 18 years. They all had viral loads of 1,000 copies per mil. They were started on DTG. By the end of 144, 16 were still in follow-up. And the virologic outcomes for viral load less than 400 copies at 144 among these was 43%. For those less than 50 copies was 35%, but very, very importantly, many of those who experienced treatment failure had adherence levels that were suboptimal. They were consistently below 90%. So probably that explains why the suppression rates were lower than what has been observed elsewhere. But on the other hand, DTG was very well tolerated. There were no adverse events just to be probably or definitely related to studied drug. When the genotypic resistance testing was done among those that had failed, from 6 participants, one of them had evolution of integrase inhibitor resistance. Some of those mutations, it's important to note the R263K that really confers a greater level of resistance to DTG. And in fact, when they looked at the phenotype, the resistance was a 5-fold change. So meaning that DTG could not be used in this child anymore. So as we use it, we should note that amid its poor adherence and not taking it optimally, resistance can develop, and we should look out for it. Now, DOLPHIN 1 was a safety and pharmacokinetic study on DTG in pregnant HIV mothers and their neonates. This starts as a pilot study. There's DOLPHIN 2, but for now, I will focus on DOLPHIN 1. So this one was among 60 treatment-naive pregnant women living with HIV. They were recruited at 28 to 36 weeks of gestation. They were randomized to receive either DTG or a efavirenz-based ART until 2 weeks postpartum. These women were recruited in Uganda and South Africa, and the primary endpoint is pharmacokinetics of DTG in women, as well as their breastfed infants. And as a secondary endpoint was to look at the maternal and infant safety, as well as viral suppression. Remember, these are only 60 women, so the comparison may not necessarily be powered to assess the virologic outcomes. So what was found? Even the infants received some. Were median, oh dear. Okay, hope things will be back, the slides will be back for everybody to see. But as I was saying, the median age of the women was 26, and the weight, median weight was 67 kilograms. And importantly to note that when they monitored, they checked the blood levels for the drug among the infants. The drug was only given to the mothers, but there was transfer across the placenta, and even through breast milk. And it was observed that the infants eliminated dolutegravir much slower than that. So that led to some infant exposure of DTG through the placenta and even through breast milk, which means that as you give a mother DTG, even the infants receive some. So both regimens were well tolerated, whether it is DTG or efavirenz. There were no significant differences in frequency of adverse events. Important to note, even the infants received some. So both regimens were well tolerated, whether it is DTG or efavirenz. No congenital abnormalities were observed among these children. And DTG, as observed in many other studies, resulted in faster viral suppression postpartum when compared to the efavirenz-based regimens, even if this was just a small sample of 60 participants. The median time to less than 50 copies per mil in the DTG arm was 32 days, as opposed to 72 days for the efavirenz arm. So even meaning that even for PMTCT, DTG is still a very good regimen or the regimen of choice. And that also becomes encouraging that we have some data on efavirenz and how the neonates metabolize efavirenz. Important to note that they metabolize it slowly, and it leads to lower degradation of the efavirenz once the neonates have it. What about the studies that I'm going to present are pharmacokinetic studies among neonates, but they are dependent very largely on modeling. So this study is published recently, prediction of DTG PK and dose optimization in neonates, and this is really a modeling study. So the objective was to model the dose of DTG in neonates and to stimulate a theoretical optimal dosing regimen. So the procedure of doing this was to get a model that was built on incorporating the age-related changes that are observed in neonates. So they came up with virtual neonates between 0 and 28 days simulated in this model. So the model was validated against observed clinical data for tegravir as well as midazolam, where the data was available for neonates. Now, the results showed that in the first 3 weeks of life, a dose of 5 milligrams of dolutegravir administered every 48 hours achieves plasma exposures that are needed for both therapy and prophylaxis. So I think this is important, that we have a dose that we can be able to test, at least, or be able to give when one must give dolutegravir. So the dose here that was predicted here was 5 milligrams, but of course this has to be tested in formal studies. A dose of 5 milligrams administered every 48 hours, that gives the exposures that are necessary. Then another one is also a modeling study, and it is based on modeling and simulation. It's also published actually earlier this year in January. So the objective was to assess the DT dosing requirements during the first few days of life, and as a function of maternal DTG history before delivery. So here the DTG PK data obtained from pregnant women and infants in an earlier study, the P1026S, were used. Then they used what they call the Monte Carlo simulations to stimulate neonatal concentrations after 2 doses of DTG after birth for infants who were either receiving or not receiving DTG before delivery. So the results are that in these infants, a dose of 5 milligrams at 24 hours after birth, with a second one at 48 hours, maintained the concentrations within or nearly within target range, even if the maternal ART was taken as soon as 6 hours just before or as long as 24 hours before. So there is a bit of range there, but what this means is that 5 milligram dose, remember even the first study talked about a 5 milligram dose. The other one was talking about 48 hours. This one, when you give it at 24 hours and then at 48 hours, you maintain the concentrations. So 5 milligrams seems to be the dose that we're thinking about, and probably either thinking about it as either every 48 hours, or at least you say 24 to 48 hours. So we have some information on how much DTG the neonates could receive. So in conclusion, we see that dolutegravir-based ART is highly efficacious and safe among treatment-naive and experienced children and adolescents living with HIV. It's been found that dolutegravir is safe among neonates, and now we have some pharmacokinetically simulated doses available. So we could probably start thinking about using dolutegravir among neonates. Remember, at the moment, what is recommended is dolutegravir. The current evidence that we have in adolescents, children, and even neonates, or even the younger children, the light ones that are less than 14 kilograms, supports the rollout of DTG-based regimens in all age groups and probably across all weight bands. I'd like to acknowledge the ODC team. Some of the slides that were shown here were original slides, as well as the conference organizers for inviting me to make this presentation. Thank you very much.